Since 1954, when the neuroleptic drug Thorazine began to flood the state hospitals throughout the nation, what was once the psychiatry for the poor, biopsychiatry, has now become the psychiatry for everyone. In fact, since former President George Bush signed a congressional resolution declaring 1990 the first year of the decade of the brain, diagnoses such as depression, anxiety, and attention deficit disorder are routinely treated with psychoactive medications designed to address the biochemical imbalances which may be the foundation of the emotional pain which disrupts our lives. Tonight, we will address the biochemistry of two major disorders, depression and anxiety. And with us to tackle this complicated topic is returned guest Dr. Bill Hazel of HQI and NATO in Los Gatos.
Hi,
thank you for returning to us this evening. Great. You know, medication, psychiatric medication in general, is often fairly controversial for people. Right. You know, on the one hand, people think, well, if this is true, the biochemistry really is the answer. That's a very exciting thought. On the other hand, people sometimes are a little leery about the medications and have pictures of being zombied out and not able to function. And I imagine you've had patients express those kind of concerns.
Yeah, it's regular. I mean, it's daily. People come often because they have no recourse. They've tried the alternatives, or they're in such a state that they need something to happen quickly, and they don't have the time to experiment and practice with alternatives. Part of the issue is that when you tie in a medication, a pharmacological medication, you're also tying in the diagnosis, you know, and it's a psychiatric or a mental diagnosis, and people really react against that. Otherwise, you see you've got a stress problem, you've got a family problem, or you've got a problem with something that's not considered a full medical problem. And people don't like being labeled having a mental or psychiatric disorder. So that's one of the big barriers.
I would guess so, that is one of the hardest parts, which is that you can't just take the medication without identifying why you're taking it.
Right. Well, see, it's just the true medical model where you have a diagnosis and then you have a treatment. Well, the diagnosis is some mental disorder and the treatment is very psychiatric, very mental. And certain medications have stigma. You can just utter the word and patients will, you can see their body change as they react to the sound of a certain word.
Can you give us an example?
Lithium.
Lithium, okay.
Lithium for people sometimes just sends chills up and down them, even though clearly they have a presentation of a patient who would need lithium. Okay. You know, rapid mood cycles or mood cycling that's had a chronic history. And, you know, with a short course of treatment, the whole thing could be different. But the idea of mental hospitals and severe mental illness, just that word can cause people, I've had people leave my practice during a consultation just because, you know, I uttered the L word. You know,
okay. Well, you know, speaking of the L word, lithium, let's take a look at our first graphic where we're going to look at depression.
Okay, good.
And we do have a list there of the different types of psychiatric disorders. We have bipolar depression, clinical depression, we have cyclothymia, dysthymia, and then sometimes we add in adjustment disorder with depression.
Right.
And I would imagine all of those probably seem familiar to you at some level.
Right. They're the bulk of my practice, actually.
Oh, they are? Okay.
Well, my practice is solely pharmacology and the evaluation and treatment of disorders with medications.
Okay.
So the majority of patients are probably depressed in one form or another, and most of them would meet one of those criteria that you just listed.
How do you differentiate between, oh, I'm going through a difficult time, maybe my husband just left me and I'm feeling depressed, maybe the adjustment disorder, versus I might need to take some medication? I mean, how would...
Well, this has been a problem for decades and decades, and the American Psychiatric Association, you know, went to the model of, you know, the DSM, Diagnostic and Statistic Manuals, and they're up to DSM-4 now, and there are clear criteria for each one of those disorders that you listed there. Okay. And they have to do with symptoms and the presence of certain symptoms and durations, history or durations of the illness. Okay. So having a bad week because of some problem at work might be an adjustment disorder, meets that criteria. Okay. Whereas cyclothymia or dysthymia or major depression have very different criteria. Okay. And so in some ways it's very straightforward.
Okay.
And part of the practice that I use in the office is to go through those with the patient, so they can see that, well, gee, yeah, I've had insomnia and weight loss and poor concentration and irritability for months and months, and I clearly meet that criteria.
Okay, so that's a wonderful part of your practice then, that you actually engage the client in understanding what's going on with them, and maybe even going through their own diagnosis with them.
Well, yeah, you have to, and they have to be educated. And with the newer products we have now, there's a lot more promotional and educational materials available that are patient-oriented, so that really helps with compliance and understanding. I have a couple of videotapes that are produced by pharmaceutical companies, and they're great for helping people understand and accept the diagnosis as they're getting treatment.
Okay. Well, let's take a look at some of the medications you might choose if you were going to have to use one of these diagnoses. Some common medications. You mentioned the newer class.
Correct.
The newer class tends to be these serotonin reuptake inhibitors. Otherwise, on the street, we know them as Prozac or Effexor, Paxil, Zoloft. I'm sure even as we speak, they're probably creating new ones.
Right, there's 4 more actually.
There's 4 more?
Yeah, that have come out.
Okay. Why are these so hot right now? Is it just because they're new?
Well, they're new, correct, and they have a new mechanism of action, or maybe a refined mechanism of action, but the whole success behind these would be low side effect profiles, and they're very effective. Okay. So when you have an effective medication that it produces fewer side effects, you've got a good product.
And yet, I know from my own caseload that there are occasional side effects. I mean, they're not as severe as maybe some of the heavier ones, the tricyclics, but some of the common side effects might be things like difficulty with sleeping, or maybe feeling kind of a little bit zoned sometimes is the word that clients use.
That's
but
correct.
Does that have to do with dosage and that sort of thing?
It could have to do with dosage and how the medication is being taken, the time of the day it's being taken. It could be just individual differences in how people take medications.
Okay.
You can give the same product to many, many patients. You can get so many different reactions.
Okay.
And my strategy is to basically start with the same product so I can sort of predict what I expect to happen.
Okay.
And then if it doesn't, I know there's a problem area.
Okay.
Some of the medications that are stimulating will sometimes make people drowsy.
Okay.
And they have to be given at night instead of in the morning. And most times you don't know that.
Okay, so we're really talking about some careful monitoring. Let's take another look at our graphic again, where we had the next level, which were the tricyclics, which are things like tofranil, Elavil, Atipin, norpramin, Pamelar, and then we have the atypical antidepressants, Ascendin, Desiril, Wellbutrin.
Right.
When we use the word tricyclics, my understanding is these are the old guard.
Correct.
These are the first antidepressants that we had.
Correct. Yes. Yeah. These have a history, 30, 40 years. They're still very good products. They are very effective. That actually the newer products may not be a whole lot more effective than the older ones, but the side effect profile is so different.
Okay.
Mipramine kind of being the standard for the old guard, and Prozac being, because of the newest one, and maybe one of the best ones, being sort of the standard for the new guard, or the newer products.
Well, and one of the concerns I know that I've had clients express about using Prozac or even imipramine has to do with their fear that when they come off of those types of medications, that the depression will not only come back, but the depression might be worse. And I'm wondering if you've ever seen that.
That is true.
Okay.
Majority of depressions are recurrent. The depressions I see are depressions that have been present for a long time. Okay. You have the individual or single episode depressions. Yeah, that happens. But a majority of patients that I see have had multiple depressions, and they get worse with time. And when you come off the medications, there's a high risk of having another one by nature of the illness. This is an illness. Okay. This isn't, a bad day or a bad job or a bad life. People start with their depression sometimes early in childhood, and as they go on through time, they worsen. The episodes are more severe, the episodes are longer. So going off of medication, yeah, you can predict that fairly soon there's going to be another episode, and it's going to be worse than the one before.
Okay. So it's like a lot of other illnesses where perhaps it goes into remission then.
Correct.
And we don't know if it's going to come out of remission or whether it will stay in remission,
Right.
which is why sometimes people have one episode and why they have maybe a recurrent
Right.
episode 10 years later, for
Right.
example.
Right.
Okay.
There are good statistics, though. You can predict pretty much based on how many episodes a patient has had and what their age is, what the likelihood of them having another episode, meaning like within the next year or two.
Oh, okay.
So they've researched this very well. So there are very, very predictable numbers.
Can you take just a few minutes here and explain to us how these work? I mean, do we know, for example, that the serotonin reuptakes, I mean, can we prove that those medications affect serotonin? Can we prove that the old ones might affect norepinephrine or one of the other neurotransmitters?
Yeah, there's pretty good scientific evidence that these products affect certain neurotransmitters, serotonin, norepinephrine, and dopamine. So that's pretty much a fact. The unknown is, well, why then do you raise the serotonin level, say like with a Prozac or Paxil, and then it takes weeks for it to have an effect?
Huh.
You know, you get an immediate increase in serotonin, but why don't you feel better right away? Why does it take 3 or 4 weeks? And why does it change later on? Maybe you have to raise the dose. So all that takes place within the brain as far as changes and receptor changes and those sorts of things. We're not real clear about what goes on in there.
So in some ways, it really is an act of faith to go ahead and try the medication.
Right.
And basically, it sounds pretty much like common sense, which is if the medication works, you stay on it.
Correct.
And if it doesn't work, you either you change or you decide maybe another route in terms of healing.
Correct.
We're going to take a quick break.
All right.
When we return, we will hear from a man who shares his experience with medication. Stay tuned.
In my own personal experience, 10 years ago I was diagnosed bipolar, and I'm personally in recovery myself. And at that time, I finally got in front of a psychiatrist, got diagnosed, and I was really tired. I was on methadone maintenance, and I was addicted to heroin and cocaine.